Am I missing something? I thought I was late.
Yeah, but we had a problem opening up. I just got a hold of Angus.
Oh,
Okay, I finally got in. Okay, got it. Okay, cool. Okay, looks fixed. I better send another email out now saying it's fixed, whatever.
Yeah, Paul, I'm not sure what the problem is. I think you might be logging in on the wrong thing. Remember, we had to change your login to be able to
Okay.
start it.
Yeah, let's try after this meeting, let's go and maybe we'll do a Zoom or continue this Zoom and you and I can work on that then. So, okay.
I actually can't stay on, but I'm going to change you to the host here, so it should work. I see 34 people in it right now.
Okay, good. And then, but can we go over that to make sure? Because when I click on my thing that I have in my calendar, this is what it comes up
Yeah,
and I want additional
yeah,
password.
we absolutely, I just can't do it today.
All right, got it. All right, well, let me know when you can do it then. Thank you. Okay.
Angus, I tried a couple different ways with a couple access ways, thinking I had it wrong, just so you know.
No, it's Paul has to, I have Paul set as an alternate host and he has to go in through the right account. That's all.
We probably should create two alternate hosts or something like that, just in case something happens to me as well. Okay, handled. Okay, okay, join us. Okay, join us. Here we go. I'm just sending an email to everybody again. All right, got it. Here we go. Okay. So let's see now if I can find Zoom, that thing. Okay, here we are. Okay, good. Good to see everyone. And I am now the host, apparently.
All
So
right,
that's
you're in
good.
charge now, Paul. See you later.
Thanks, Angus. Yeah, I feel like really in charge. I'm going to move a lot of people over here now. Here we go. Let's see now. Promote the panelists. Charlie. Okay, here we go. Crawford. Okay, thank you, everybody. Hey, Jim, I got, for some reason, they gave me the, what do you call it last night? The CME numbers. Put in the thing, were backwards and they fixed them this morning. So 23. 23100 will be the Seagulls, and then we're 23101. Okay, if you could put that in the chat so everybody knows
Will
that
do.
that's a correction. Okay, got it.
All right. So
Okay.
the 101 is the Eagles and the
Yes.
100 is the Seagulls.
Yep, you got it. Uh oh, you can't, it looks like Crawford can't do, he must be in the ER, I bet you. So we'll see. Doug, here we go. Okay, we're having fun today. Dustin, nice of you to join us today. Eric, okay, here we go. I'll be with everybody hopefully in a couple of minutes. So I was going to show a funny video if I can get it going. A friend of mine from Germany gave me this great video. I was trying to speak in German at a conference one day and I wasn't doing a good job. So he made me feel better by sending me this video. You'll see.
And Paul,
Okay.
I'm here.
Oh, you're on. Okay, good. I wonder what it said at first you were declining, and Doug
Uh,
says he's
I
declining
have no
as
idea
well.
what that means.
Yeah. You have double audio though, it seems like though. Okay. So it's just so you know. Huh. Now I got lost here. What happened here? Okay, something popped up here on my screen. All right, let me see. Hey, Kim Gifford, I'm coming to you in a second. What you'll see is that I'll click on a thing that says promote to panelist, and so then just accept it, I guess, and then you get on. Okay, so thank you. Alrighty, good. Okay, you got it. Okay. Yeah, I'm sorry this is taking so long to do this. Is Mark C, is that Mark Cohen or who is that? Uh, I hope. Well, I guess we don't know yet. Okay.
I say I'm already on, so
Okay, got it. There was another Mark C iPad. That's why I don't know who Mark C iPad is then. Okay, here you go.
not me.
God, this is quite a group that's coming out of God that I'm pushing over. So let me see who this is. Okay. Maybe a lot of people went, oh, I know what happened when people couldn't get on the usual way. They probably switched over to this. Okay, Ray, I'm trying to get you on. Rob Lowe, I'm trying to get you on. Okay, Roger, here we go. Put you on. Thank you for joining us. And so I got Sebastian Sanko. Is that the same thing as uh okay, as Stephen? Because it says Sebastian there. So all right, Rob, thank you. Sorry this takes so long to get this done. And then Nick, I'm trying to do you, and Matt Riesenberg trying to do you. Okay, got it. Think we're getting close. I'm gonna try Doug one more time. I don't know if he can get on or not, or if he's busy. Probably busy, but we'll see. Okay. Oh, you're coming on. Good. Okay. So this is cleaning up now. I think we're finally getting places here. And Crawford, you're definitely on, right? And you're okay?
Yeah, I'm hearing an echo, but I'm not sure if that's just in my head or what that's all about.
Yeah. Okay. Got it. I'm hearing it too as well, but that's okay. I just won't talk to you today. Okay. So how's that sound? All right. Good plan. So anyways, let's start this up. I don't know if there's other people who have to come over, but we have a pretty good group on today, everyone. And so I guess what I want to do is share with you this thing of this friend of mine sent me. And let me see if I can, how do you do the share thing? Okay. Share, share, share. Here we go. And I think, can you all see my screen now? And there it is. There's the emails I've been sending out. Now I just got to find this PowerPoint. I think it was. Yep, here it is. So this
We
is
can
the,
see everything, Paul.
you can?
Yeah.
Can?
Yeah.
Okay, good.
Yeah.
So this is the German Coast Guard first day on the job, right? Just want to play this here. Let's see what happens here.
Das hier ist ein Mine-Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
I'm playing this in honor of May Day. You'll see.
Hello. Here. We are thinking. Hello. This is the German Coast Guard. What are you thinking about?
So anyway,
Mindset.
okay, let me get out of that. There you go. Well, thanks for putting up with me on that. I guess why I had this up though, there was another picture I took last night. Let me see if it comes up on my photos. Yeah, here it is. There it is. So just wanted to show you, this was a video that I got last night. Here's the beach over here. This is something called Pier 66, and there's a bridge that crosses over to sort of the mainland. So to
Can't see
speak.
it, Paul.
Oh, you can't?
No,
Did I
can't see
yeah,
it.
I must stop sharing that. Okay, thank you. That's probably made a mistake and stopped the sharing part. So let's see. Oh yeah, I did stop sharing. Okay, let me come back to that again. All right, can you see this now? Okay. Can you guys see this video, this picture here? Does it come
Yep.
up? Okay.
Yep.
So
Nice
what you
harbor.
see here is this is so I want to show you, this is the brand new convention center, and it's got this patio deck out here. They call it the lawn. Here's the Omni, where we can't get in this year because there's someone else having a convention at that time, but we'll be there next year. Meanwhile, our hotel is right over there. I'm circling it. It's called the Renaissance. And so we'll be able to still walk across. You have to walk across the street, but still you're fairly close. This is something called the 17th Street Causeway, and I'm going to try to see if I can pull this over here that you can see this. And you can see there's a really a kind of a swanky place called Pier 66 over there. That round thing. It's got a nice little round top bar. And then as you move over here, you can see there's the beach. We're right there. And then I'm talking to you right now from, let me see if I can get this to show up again here. That was from me taking from that airplane flight. That's where I'm talking to you from, right here. So, any event, just for, but I just wanted to give you an idea of how close we are to the beach and how much this will be fun. There's a lot of, and I'm going to set up a thing. There's a deal over here, if I can pull back again, called the water taxi that you pick up right there by the Hilton, I think it is. Okay, and there's a couple good, really good restaurants around that area, but. Chris Caldwell, did you take that with us one time, or are you here? Are you on today? I don't know if Chris is on or not. But anyways, I'll stop sharing at this point in time. And so it just, there's lots of fun things. So over the next week or two, I'll start telling you about various things that you can learn about for our upcoming meeting. So meanwhile, in the agenda, let me see if I've got anybody on. Hey, Chief Sinkyu, are you on by any chance? And she's not, then I will hold off on that. Hey, Tim Sadie, we just want you to know your folks did a really good job. Beth did a really good job over on the Seagulls talk about, looking at differentiating COPD from CHF using ultrasound and all that. Ken, you were over there and you made some comments about it. How did you like the presentation? That's Tim's people there.
Yeah, it was pretty interesting. I mean, I didn't get to read the studies they quoted, but the studies they quoted makes a pretty good case for this greatly expediting the diagnosis of CHF, as well as making it more accurate, both in the pre-hospital and emergency department fields. And I just see how artificial intelligence can make this a lot more effective over time. Ultrasound with an AI component can make the credentialing and the training for paramedics really easy. I could see us bringing LASIK back to the field again. Or even if we don't do that in the field, making it easier for the emergency physicians to do this right up front rather than waiting for BNPs and chest x-rays so we can start treating these folks much earlier in their clinical course. Not to mention the ability to use this for CHF patients that are discharged home into a remote monitoring or hospital at home type condition, to have visiting paramedics use this as opposed to x-rays or whatever, give you a real-time evaluation to notice before patients clinically decompensate. But I think it's an interesting modality that's probably gonna have some utility in the future.
Okay. Hey, Johanna, Chief Senku, I just want you to know that I'm trying to do a thing where I promote you to a panelist. So you should be getting a message, and I need you not to decline it, but to accept it if you can do that. I've never done it myself, so I just want to make sure that you're saying that. That's how I'm going to get you on. That's all. So let me do a thing that says allowed to talk. Okay, see if that worked at all. Are you able to hear us now, Johanna? See, I don't know why, maybe for wherever you are, you can't get on or get over on the panelist side. Okay. Okay. I don't know what else to tell you. When you guys get that message, when you switch over, do you end up, what do you see? Do you see a message that says you've been promoted to panelist? What comes up so she knows what to do?
Yeah, it says some words like that you are being invited to rejoin as a panelist. So it may be confusing folks with the term rejoining.
It'll not let me unless I'm on a desktop. Oh, that's interesting. Have you guys had that problem before? Okay, she said she's
No.
getting her laptop on. Anyways, I want you to make everybody know Chief Senku, because she's like Gail Bennett was, like Candace was, etc. And she's going to be our point person. She runs the whole meeting. She's just amazing. And so hopefully she will get on. And then Johanna, if you do get over on your desktop or laptop or whatever it is to get yourself over, then let me know or text me and I'll pull you right over, because I want to get some other things started. Let's go back real quickly to Ken. Dr. Shepke, if you don't mind, I think there's a very important announcement. Somebody who has just done an amazing life. I would trivialize his career if I was to talk about it, but he is now ending a term and he's going into a whole new world. They, of course, created something special for him. So why don't you tell us what that is, Ken? Okay.
Yeah, sure. So I think everyone knows I've been the Deputy Secretary for Health for the state of Florida for the last, I guess 5 years now. And when the governor leaves his term, and Governor DeSantis is term limited, pretty much the entire executive team leaves. So I've been looking to leave anyway because I have to spend a lot of time in Tallahassee away from my home in Jupiter. So I told them that I want to basically leave after this last legislative session, which was DeSantis' last one, ended. But they asked me to stay on, so they actually made a part-time position for me that I can telework from my home in Jupiter, where I am now, as opposed to being up in Tallahassee all the time. So I still have a lot of the same functions. I still report straight to the Surgeon General, but it's part-time instead of full-time. So now my title has changed. I'm now the State Chief Medical Officer for Florida. And I get to do a lot more fire rescue ride time, which is great.
And Ken can't say this about himself in a proper manner, I think, but I can, is that they absolutely love him up there at the state and at the health department. And they wanted to create anything to keep him on. So they actually created this position for him, the state chief medical officer. And so anyways, I don't know, is there a way we have to salute you or something, Ken, or is there a secret handshake with the new job, or I don't know. But either ways, I just think it's, I just want to say it really does say why he's in that position and why they've created this new position for him, because he's invaluable.
Being part of this group is privilege enough. It's a group of very talented people here. I learned a ton from all of you. It's been really helpful. I've said this before. You guys have helped us in the state of Florida tremendously, because I learned from all of you, from what's going on around the world, and we apply those lessons here in Florida. So thank you all for what you did.
Hey, Ken, one thing, there's someone that I want to introduce you to who's going to be in that part of the world and has good context down there, is our guy, Brian McNally, who, Brian, tell him where you live, okay, and what part of the world you're in most of the time. Brian McNally, I'm picking on you, if you don't mind. Brian is the
Oh,
person who
yeah,
runs the
Atlanta,
Hope.
Atlanta or Asia, one or the other.
Yeah, the reason why is I know that you're over in the Vietnam area, but Ken is going to Bangkok, and you're really familiar with that. I just wanted to have a contacts over there when he goes over there in case anything does happen with his family or whatever it is. So I want to get you guys together sometime, right? So that's
Sure.
all. Yeah.
Happy to. And I'll call ahead and warn him it is coming.
Yeah, that's what I was gonna really say. That was the whole intention here, right? That's right, exactly right.
Actually, I saw Hangover, so we're going to avoid Bangkok. We're going to go to Phuket and Krabi.
Yeah.
We saw the dangers of Bangkok on that movie.
Yeah, so I thought you'd get a kick out of this, Brian, because he's going down to Phuket, so which is a great place, right? Yeah, I love Phuket.
Yeah.
I did warn him about driving on the left-hand side of the road, though, right? Down there. It's if he gets a car. All right, so I think Johanna, have you rejoined us yet, or where are we on that? I don't know if she's switched over yet. I want to try to promote her because I want to get on with the other talks today. Okay, still not working yet. Well, hopefully she'll let me know when she's ready, willing, and able. And so we'll go ahead and get some other talks started. Anybody that has to get off early, by the way, and have a deadline. Amal Hama, how are you doing on time?
I've got about 45 minutes.
Okay, good. How about you, Don? How are you doing on time?
I'm gonna probably be called to the operating room in the next 20 minutes.
Okay, so we're going to put you on first. So, I was going to say, how many lap colis do you have waiting for? About 3 or 4 at the same time, right? So
I know there's a bowel perforation. Is not good. Not good.
Oh, just a minor bowel perforation. Okay, good. All right, good. So you don't. Maybe we should make it 15 minutes for the poor person, right? All right. Well, listen. So one of the people that's been really on top of the whole game about whether or not we should be giving calcium to our patients, we all kind of understand that after the transfusions, that might be a good time. But there's also other times where we've just noticed hypocalcemia for whatever reason that's been associated with major hemorrhage and trauma. And so we wanted to sort of get a feel. And then there's been different kinds of studies that have come out. And of course, like everything else, it's not that something's good or bad. It's sort of when you use it and how you use it, et cetera. And there's a latest study that just came out, Don, a week ago that we actually told the people here on the call last week that you'll try to present that and give your perspective about if these data say this and these new data say this, what should we tease out of that? What's your opinion? Because, has anybody's got experience with this, it's you. Okay. So if you don't mind, take it away.
Can you see my screen, Paul?
Yeah. Only the thing about aggressive calcium chloride dosing. Okay. No, we can see it quite well. Okay. Go ahead.
Yeah. So we just presented this at the East meeting in January, and there's a couple of things, some caveats to this that we have to review as well. But the essence of this is that injury severity can dictate the arrival of a patient with hypocalcemia, and the higher the injury severity, it appears the worse the hypocalcemia can be. We did a study from here and from Colorado where we looked at this together, over 1,000 patients put into that study. And what we found was that the incidence of hypercalcemia in those same patients was about as prevalent as hypocalcemia. And the mortality, the inflection point for that mortality is in this happy spot with a ionized calcium level right in the 1.1, 1.2 range. And if you get much outside of those ranges, the mortality starts to go up. And so that led us to look at our own practice here.
And Don, let me interrupt you. I just want to make sure it's clear that people understand that greater than 50% of the hypocalcemia that's recognized, and but it's not all from blood, right? This is like you're just observing that they have a hypocalcemia, correct?
Yes, exactly right.
Okay. And what percentage of patients do you think that is if you take out the chelation and all that?
It's if they're needing emergency transfusion, it's probably a third.
Oh wow. Okay. So it's significant. Okay, go ahead.
Yeah, it is. Yeah. And so what we decided to do is what's the right drug to use? because our pharmacists have a tendency to want to do an infusion with gluconate, and I'm an impatient surgeon, and I don't want to take hours to correct this hypocalcemia. And so we looked at our patients who got emergency transfusion within 4 hours of arrival to us. Didn't really need to look at the dead people or those that got no calcium at all for the purposes of this study. And what we looked at was some ranges of calcium per unit of blood product provided. Now, this is all provider choice, right? They just made the decision. I want to give a gram. I want to give 2 grams. I want to give chloride. I want to give gluconate. And we just did an observation of that. So we ended up with 273 patients in this grouping after the exclusions. And you can see it's about 50-50 on chloride or gluconate and mixed. So there's some people that got both agents in this study. These are predominantly men, but we will highlight this female thing here shortly. And their arrival calcium level sitting at 1.02 per the mean. And what we looked at here, this is the money slide for
And
this.
that's ionized. So those are ionized calcium levels. Am I right?
Ionized calcium levels, yeah.
Yeah. Okay. Good. Okay.
And so this is the money slide here, because what you see is the higher dose calcium patients had the best mortality in this grouping, survival of 93% practically, whereas that drops off with lower calcium dosing. The other thing to note is that this is the thresholds that we looked at over that same period of time. And again, the only things of significance were those with the higher ratios of calcium per blood product infused. And when you try to look at that as a continuous, what you can see is that for every additional 0.59 grams of dosing, there was a 63% reduction in odds mortality. And when we parse that out between the chlorides and the gluconates, what you can see is that the chloride patients fared better than the gluconate patients overall. And so what that really then shows us is that there was no significant reduction in mortality between those thresholds in this study, but the factor that really comes into play here is how the CPDA in that or the citrate in that blood that's being administered to the patient adds to the problem. And so the more blood you get, the more calcium you need to overcome that. And chloride, because of its bioavailability and the immediacy, solves that problem more readily, and certainly does appear in this single institution retrospective look like it really helps our patients, and giving the gram per every 2 units of whole blood, at least in our hands, connotes a survival advantage. The one thing to keep in mind is the other part of this study that we looked at in the 1,000 patients was that we had 270 women in that grouping. And in general, given injury severity for injury severity compared to men, women had a 30% reduced odds of hypocalcemia on arrival. So if one were to administer empiric calcium, you probably ought to think twice in women and do your best to get an ionized calcium level. Dave Miramontes and CJ Winkler and I have looked at this, talked about this, and we've decided that we probably shouldn't give empiric calcium in the pre-hospital setting because of the increased risk of hypercalcemia in some of these patients, and more especially developing hypercalcemia in women. So that's what I wanted to share with the group today.
So Peter, before I go to you, Don, I think I put the correct reference in the chat. If you could take a look over there, it looks like it is. Okay, I don't know if anybody has been able to open it or not, or see if that's the correct reference that you published. Okay, so I'm intrigued by, and I'll be going to Dave in a second. Miramontes to prepare, David. I want to know what your protocol is there, because it sounds like Don just told us, but then I just wanted to see if we're saying that we should be more aggressive. You know, we always think the earlier intervention, the better results. So I'm left a little bit up in the air at this point in time. So to see how this plays out, I'd like to see Don. You know, I'll ask Dave in a second, but let's go ahead and take Peter's question and/or statement.
Yeah, I do have a question, Don. Great presentation. Thank you. My question is, when we know that PRBCs have 4 times the amount of citrate, and then most agencies are giving 2 units of PRBCs as compared to the 1 of whole blood, did that change the equation for you with respect to calcium administration?
So, Peter, I might have been able to answer that question 8 years ago, but we don't give components, man. We don't have components to give for the most part.
Right. So I guess my question then is, if you're in New Orleans listening and they give 2, 2, and 2, right? Would you advise them differently than what you're doing in San Antonio, which is, hey, we don't have to worry about that?
Yeah, the advice that I would give to them is you need to look at your patient population. Right. We did this study specifically to make a decision about whether or not our patients would benefit from empiric calcium replacement. And it was the Steve Schauer, Susanna Nicholson study that showed this high level of hypercalcemia in these like similarly injured patients that caused us to want to get this look and try to help with data to make a decision about giving it or not. So I would just advise them that they should probably just look at their patient population.
Right. And then because there is an extra, but I guess the implication there is that there's extra chelation going on with all the different components. So let me go ahead and then turn to, okay, you're just a little regular EMS medical director in a town of 1.9 million people. And what are you going to do out there, David, with all these data that say it's going to save a lot of lives if you can treat that should you do it for the males? Should you not do it for the females? Or how'd you come to your conclusions?
Well, the meme goes, I ain't got time for that, right? That's the meme that we see all the time. And I'll tell you, I want my guys to focus on what really matters. Stop the bleed, push back a tourniquet, get an airway, open the chest if you have to, get the cluck to the truck, and then we do the 3 things, which is push 2 grams of TXA, give the blood, and if you have time, give antibiotics if it's open wounds. If I add calcium onto that, it's operationally problematic. Okay. And what we're going to give it, right? That means you'd have to have another line because you can't give anything with whole blood. Yeah, whatever. Okay, I know. You're giving blood in blood. I get whatever. Anyway, my point is that I don't want to muck up my operational tempo. And especially when Don tells you it might be harmful, I got to say, hold off, right? They've got this beautiful thing called a lab in the trauma bay, and they can get ionized calcium, and then you can figure it out. I think we need to focus on what's important in saving lives, and that's the basics. Stop the bleed, get an airway, open the chest, give the blood and the TXA, or TXA then the blood, rather. So the reason why I said that on purpose is because operationally you want the TXA and then give the blood. Right. So you're not mucking up your line. And I'm going to tell you, I'm a RN. I'm a recovering nurse. I screwed up a bunch of IVs in my day pushing calcium chloride, and
Okay.
it's a very sclerotic agent. So if you lose your line, now you gotta move your blood. You got to do an IO, whatever, right? So I just don't think it's a great idea, personally.
All right. So the next thing is going to lead to a series of couple questions for you and Don. The issue, for example, of not so we got the idea, but at the very least, we can be talking to our trauma surgeons saying, "Hey, are you aware of the study? And will you please quickly check the calcium when they come in? A lot of them have it, and if they do have hypocalcemia, please be aggressive about it." Now, let's turn over back to what we found about the women. What do you think is Don, is the mechanism with women? And did you sort out those who were premenopausal with the estrogen versus those postmenopausal? Is there a difference there?
Yep. So that part is underway to tease out if there were hormonal activity differences there, but that's what we think is at play. They just have a better, more stable calcium metabolism than their male counterparts is all we can come up with.
And probably you're seeing that because most of them are younger people that are usually involved with these kinds of cases. But so have you specifically, you did sort out those who are, say, over 55 versus those under 55 by any chance?
Yeah, we're doing that currently.
Okay, and that's why Jim Augustine is asked. Jim, can you so that answers your question in a sense, Jim, that they're working on it. We're working on it.
Thank
Jim,
you.
go ahead. Tell us why you brought that up.
This is such important information. It would make a huge difference. Our blood is a 50-50 male female, and frankly, a lot of those females are older in our population here in God's waiting room, and that would be critical for us to change.
Okay, well, good point. Okay, so all right, so I think this was helpful, and it sounds like it's even helpful for those who were already given the calcium out there. So I think that's great. Dr. Shepke, you have your hand up. Okay, go ahead.
Yeah, quick question. With the what you're seeing with the predilection for females to have higher calcium, did you cross-reference if they're taking anything for osteoporosis or vitamin D or something like that would put them at higher risk for higher calcium levels?
That's a great question. Honestly, we hadn't thought about that, but it's now we're going to look at that and see what we can tease out. I'll need my pharmacy team to give me a hand there, but
yeah, when we did those original cardiac arrest stuff, we didn't tease out whether they're on drug or not, but there was a major difference we saw when they were taking and they had from their own natural estrogen levels. And so I think that's going to be a very interesting question that I'd like to see you take to get to that next level. Just one
quick follow-up, Paul, if you don't mind.
Sure.
So Don, would you recommend from the pre-hospital standpoint, because we have whole blood too in Palm Beach County, should we use calcium gluconate on the men and withhold it on the females, or we should not give it for anybody and just let them measure it at the ER?
What we've now written into our protocol is it is all chloride all the time.
So for the women as well, pre-hospital, you're still giving both. Okay, very good, thanks.
Yep. Now the exception to check the ionized calcium level before giving calcium is if there's ongoing transfusion. If you've gotten, one in the field,
right, we're just going to do one or at most two.
Yeah,
okay.
We're not going to hang around until we get ionized calcium for that.
Good. So I think we've got a good discussion. I'm glad Don's doing this first. Now, unfortunately, he can't make it with us this year, although he's always there for all our meetings, whether we go with ACEP or wherever he's been there for us. There was something going on in his life at that time where he won't be able to make it with us this year. So I'm glad we're doing this presentation. And I hope, David, you could carry it on for us, or whatever. Maybe you and Jim can have a discussion about that, or where we are on that particular topic.
If I could share one more thing, Paul.
Oh no. Okay. All right. Well, whatever. So go ahead. Yeah. No, go ahead.
To go along with this bundle of the ARC bundle right?
Yeah.
From our friends in New Orleans with TXA. Can you see my
Yes.
this
I mean,
grid?
it's small, but I mean, it's hard to read, but it's there. But go ahead.
Yeah. So
Circle what you want us to see.
Yeah, this represents our pre-hospital TXA and pre-hospital whole blood column here, 163 patients. And then here's the pre-hospital TXA with hospital whole blood, about 50 patients in that grouping. And what you can see is when the patient gets both their TXA and their blood pre-hospital, there is a significant decrease in the amount of transfusion required, a significant improvement in the shock index, and a significant improvement in 24-hour transfusion requirement. Mortality, as it would turn out, is not appreciably different between those groups. So, of the four combinations that you could have with pre-hospital and in-hospital TXA and blood, the best outcomes, and this is in torso injury, right? Non-compressible, non-tourniquetable bleeding. You remarkably cut down on the transfusion requirements for those patients with the combo of pre-hospital TXA and whole blood. So if you're doing it, keep doing it. If you're not, you should start.
Okay, that's great. Hey, so then, if you don't mind, could we have Dave present on your behalf at our meeting in June?
That'd be great.
All right, sounds good. Dave, you're willing to do that? You can sign away your
I don't know. Talking for Don.
Yeah. We'll have a special MOU set up for you. It's great. All right. Hey, is anybody still having a perforated bowel that needs some help? Right, John?
I haven't called, so we're good.
Before I'm going to try to get to Johanna here. Are you on, Chief Sinkyu, by any chance? Before I go to you, I want to do one thing. Bill, you sent me a paper last night about cardiological aspect of calcium. Just if you could give us like a 30-second or 1 minute summary, then put it in the file, maybe in the chat. Okay.
Okay.
But what did you? What was it?
Okay. In 30 seconds, yeah. Short-term calcium is no problem at all, and you need it if you're hypocalcemic. What we were talking about was long-term calcium supplementation appears to increase the cardiovascular mortality a little bit by 10 or 13% for long-term calcium.
Set us up. What patients are these, and who are you treating for what?
So these are individuals who are typically osteoporosis, and they're taking long-term calcium for it, and we can show that calcium eventually is part of the atherosclerotic process. You start out with soft plaque, it then becomes calcified, and we do know with coronary calcium scanning that those who have more coronary calcium are at higher mortality for having a heart attack. In fact, if your calcium score is over 200 or 300, that's the equivalent of already have had a heart attack as far as your risk for the next heart attack. So it is a part and parcel of the inflammatory process, contributes to atherosclerosis in the advanced degree. And so long-term calcium supplementation, you might expect, is and has been shown to be associated with a slightly higher mortality, about 10 or 13% higher. But these are all retrospective studies, and we do not have a randomized clinical trial yet.
So, okay. And then did you have an article that you wanted to sort of put in our chat, and then we can move on from there? So just a little, this came out in this area. So, okay, just something else for us to sort of be thinking, just kind of an interesting FYI. Okay. Ken, go ahead.
Bill's absolutely correct, but it's not my area of expertise, but just something I happen to be reading on, that if you take, for women who are taking calcium supplementation or even vitamin D or whatever, they should be taking with vitamin K2 as well to reduce the calcium uptake into the vessels and kind of encourage it to go into the matrix.
Absolutely, that's exactly what I've heard, Ken. So you have a little bit of expertise in the area, so good for you. That's great. All right, let's get. Hey, Amal, how are you doing? Are you have to get off now?
I've probably got about 15 minutes or so.
All right, good. So let me just quickly put Johanna on, then I'll go to you, and then we'll go to a very interesting question being asked by Dustin. So, and then I'm going to do Kim, I'm going to do an introduction of you after I have Johanna because I think she may have to go on. So, Ken, do you have your hand up again, or is that just you just didn't take it down? Okay, Johanna, you want to come on for us? Okay.
I'm here.
You're here. Okay. We don't get to see. Oh, there's your face. There you are. So we have to congratulate her because she's married to Chief Vince Singh Hugh, who does a lot of our help with our budgets and so on, and helping to take care of the financial ends of things. And she just runs the whole. But she runs the whole thing, the hotel interactions, whatever we're going to use at the convention center for what AV, or I could go on. She's like the person who runs the show, okay? And we can't thank her enough. And she and I have partnered pretty well over the last year to make things work for you guys. It's a little bit of a different operation this year because the hotel we were at before, the Hard Rock, was the place where we were doing this convention. Now we're kind of in a separate area. So if you want to just give, so anyways, I did want to say, although she had been a captain, doing her shift work, she's now the chief for the EMS at Coral Springs. And I think your medical director is a Dr. Anchovy or something like that, or whatever that. No,
yes.
No,
I'm
Dr.
very fortunate to have him as a medical director.
Yes, that's great. And they handle Coral, and they also handle Parkland, Florida. And of course, that's why they responded into that terrible shooting back in 2018. But anyway, so she just made chief, so we want to congratulate her and so on. I hope you get a raise, by the way. And so anyway, so go ahead and tell us a little bit about the things that they probably need to know if they haven't connected. We have 2 or 3 people that were on your list yesterday that we haven't heard from yet, correct?
Yes. So, hi everyone. It's a pleasure to be here. For those of you who don't know me, Johanna Sinkiu. I'm the event coordinator for the Gathering of Eagles and the First There, First Care part of the conference. I did put my email in the chat. So if you have not heard from me, I will be happy to resend the communication to the core group that Dr. Pepe has given me. But this year we're at the Broward County Convention Center. We have outgrown our space at the Hard Rock. And our hotel, unfortunately, the Omni sold their rooms out from under us before we contracted with the Broward County Convention Center. So we are at the Renaissance for your group, and they are right across the street. We will have a shuttle available in case there's rain or anything like that, or you just don't want to walk. But we'll have a shuttle available. If you haven't received my email, like I said, it was communication specifically on when you'll be coming and if you'll be attending Eagle Creek and the main conference. After you send me your RSVP that you'll be coming, I then send you a link where you go ahead and book your own hotel reservation. There's no cost to you. There's just, your preferences all in that link. And then your room is booked and you'll receive a confirmation directly from the Renaissance. It is a Marriott hotel, so if anyone has Marriott rewards or membership there, it is a Marriott.
And by the way, one of the people was Ben Launer that you didn't have on your list yesterday, and Matt Angelides. I think did you resend things to them yet, or are you going to plan to?
Yes, that should be done today.
Okay, fantastic then. And then
Thank
Brad
you.
and Brad, how about you, Brad? Are you coming in, and did you get an invitation from Johanna? Monsieur Dr. Keegan, do you hear me okay? He may have gotten off, unfortunately, so that may be what happened. He was on earlier today. Okay, got it. We'll reach out to him anyways, just in the meantime. And then Tom Ladaro, I don't know if he made it on here today or not. Are you there, Tom, by chance today? You're on last week, so all right. So we're all looks like squared away. Is Sean Morgan on today by any chance? Let me see if he's there.
You okay?
Okay, Sean, he's the other person that we hadn't heard from, so we'll see, because I got information about presentations he wanted to make, and then I don't see Mike Feldman on with us, so we'll follow up on him. I just wanted to see if any of the people out. Is everybody else pretty much okay? Anybody having problems or had issues? Have you made your reservations, and are you squared away? Anybody having a problem or an issue that while we're here with her?
Johanna, it's Jim Augustine. I haven't heard from you yet.
Oh, probably on
Sorry,
purpose.
unfortunately, someone just started pressure cleaning next to me, so I'm going to mute my background.
Yeah, well, Jim, that was on purpose. I forgot to tell you. Okay, so
Oh,
all right.
okay. All
Yeah,
right.
yeah.
The
No,
pink slip's coming.
yeah, exactly right. So, hey, and then Ray Fowler, we're gonna still invite you, so we're gonna resend your email just so you know that. Says we want you to be there. Everybody wants you to be here, but we would love to honor you as well. So, just important for you to be there. So, thank you so much. All right, so with that, let's go ahead and move on to the next thing. Johanna, so we're not hearing anything else, are we, Johanna? By the way, Johanna, just tell us a little bit about where Eagle Creek will be held and how do you like the location there? Is it are you happy with it, or is the power washing too much for you to report to us at this point in time?
Some growing pains, but nothing that wasn't expected. So we'll see how it all turns out in the end, and then I'll probably be able to tell you better afterwards.
Yeah, okay, good. Yeah. But you have a pretty good room set up for us anyways. The only thing that it's a little distant, right, from the main area, but not too bad, right? From what we found out where Eagle Creek will be, correct?
It shouldn't be too bad. We can make sure there's going to be plenty of signage. I mean, it is a convention center, so there is some walking. It is nowhere near the Orlando Convention Center where you're walking for miles before you actually get to your destination.
Right. And it's really set up very well. I like it. It just in that lawn area, as they called it, right? It was like a big patio that's overlooking the port. You may be able to see Steven Spielberg's yacht, etc., and all that. And so it's going to be a cool area.
So this year we're going to have 2 helicopters in our trade show, and we're bringing some boats that are close by. We have a seawall really close by right next to the convention center. So there'll be some boats there. We're going to have a cocktail hour out there. So some great opportunities for networking and things like that.
And the good news for Dave Miramontes and others is that you don't have to go to another hotel. I think you're going to be happy here.
Yeah,
Chief, thank you so much. I think this is going to be such a better setup that we're going to have this year.
Yeah, it's my pleasure. Sorry, I'm going from one place to another, but thank you guys all. Please reach out to me. If you have any questions, my email is in the chat. I'll throw my phone number in there as well.
Okay, got it. All right, well, let's move over real quickly to
one thing. So
yeah.
if you're flying out Saturday, you need the Friday to Saturday thing. Joanna was able to help work that out. So if you have to fly out because you can't get home after 5 o'clock or whatever, you just have to email her and she works the magic.
Yeah, that's right. Yeah, there's no problems extending your reservation if we need to. So all you have to do is let me know.
Yeah, and then so it's good. And what's really cool is the airport's like. I got to the airport. I live 2 or 3 minutes past where our convention is going to be. I went up and met her the other day. We did a walkthrough, and I got there like in 10 minutes from the airport. As soon as I walked in the Uber, I was like, it was 9 minutes, I think, to get there. So it's even closer. And they put interestingly enough, they put a new bypass road into the port, so it actually gets us there even faster. So it's you're gonna see it's gonna be very, very fun to do this. All right, are we okay, Amal? If I put you on now, is that okay? And then I want to introduce a couple people. Roger, I want to introduce you, and I'll later introduce Kim, Gifford. Okay, so in a second, if you can be patient, okay. So all right, so let's roll. Amal, what's up? Good to see you. You've been busy. He's been out with a bad syndrome. It's called work, right?
Yeah, work and family stuff also. So it's good to be back.
Yeah.
Well, I wanted to let's see there we go. I wanted to just present some or talk about post-arrest cath, which has become a little bit of a source of some pushback and controversy locally, and also from what I've been seeing over social media just within the past month or so. So I'll start out with the case that I had actually. 72-year-old comes in after a witness arrest, gets bystander CPR, gets one dose of epi, and gets ROSC. He never had a shockable rhythm, and here's the 12-lead ECG. And it shows a septal STEMI. There's a new bifascicular block. And again, this is 40 minutes post-arrest. So he's got a persistent evidence of a STEMI, and he's unconscious. This is his baseline. And so clearly a new septal STEMI with bifascicular block. And I think traditionally this would be kind of a no-brainer to go to the cath lab. Post-arrest STEMI goes right to cath. And we've been following this since 2015. This is an article published by Rab and colleagues from Journal of American College of Cardiology, from their interventional council. And this is the algorithm. We actually adopted this at University of Maryland and throughout our entire 13 hospital network. And this was the protocol that we would follow. And I think around the country, people started following this. And essentially, if a patient has evidence of a STEMI, the default was to go right to the cath lab. And if they had a non-STEMI, then you kind of evaluate these unfavorable resuscitation features and decide whether to take them to the cath lab or not. We kind of ignored this little line right here, which actually said that even in the presence of a STEMI, you're still supposed to look at these unfavorable resuscitation features. And if a patient has a handful of these, then they have a poor outcome, even with a cath. They say multiple, but no one's really defined what multiple is. Is multiple 2 or 3 or 5, or what exactly is multiple unfavorable resuscitation features? But anyway, we kind of ignored that anyway. And so the general practice was that if somebody has a post-arrest STEMI, comatose, and again, this does apply to comatose patients, these patients would go right to cath. This was endorsed through some other guidelines, and even as recently as the February ACC guidelines published last year, they once again endorse this concept that if a patient has post-arrest STEMI, they should go to cath. But they did once again include this concept that if a patient has any of these unfavorable prognostic features, as listed up here, then you might think twice about sending them to cath. But for the most part, I think the practice around the country, from what I hear and practice around our system and around the state, was that if somebody has post-arrest STEMI, regardless of mental status, they're going to go for cath, regardless of this information. Then recently in social media and even locally, we started getting some pushback, and a lot of the cardiologists, the interventional cardiologists, weren't so happy about this routine send all of these patients, even comatose ones, to the cath lab. And it came about largely because of an article that I didn't hear about, and most of us never heard about, and I'm not sure if you all heard about this article from 2022, and it was something called the Miracle 2 score. And this is now being bandied about, again, amongst a lot of people as a reason to perhaps rethink the idea that everybody post-arrest who's comatose should go to get a cath. Now, this was a retrospective observational study, but just real quick, what they did was they looked at a European registry of over 900 patients at 5 different centers, and they looked at their hemodynamic status as well, as in addition to their EKG, whether it shows evidence of STEMI or not. And they looked at what we've been referring to the past 2 minutes as unfavorable resuscitation features, and they actually gave a score to this, which conveniently, Miracle, MIRACLE2, this is what Miracle stands for. And what they found is that when you add up these points pre-cath, if a patient has a Miracle 2 score of 0 to 3, those, and also has evidence of a STEMI, then those were the patients that had a better outcome by going immediately to the cath lab. But they found that if the patient has a pre-cath Miracle 2 score of 4 or more, regardless of whether it showed a STEMI or not, those patients did not do any better by going for immediate cath. And so what we've been hearing from a lot of folks is that this score is being used more frequently to decide whether a patient goes for cath. So in other words, if a patient has post-arrest STEMI, but their Miracle 2 score is 4 or more, even though they have a post-arrest STEMI, they don't go for cath. There's becoming some pushback. As an aside, one of the things that they talked about in this score, if you look carefully and you have any questions, what exactly is changing rhythm? Changing rhythm essentially is any rhythm changes that occur during the cardiac arrest, anything other than going back to sinus rhythm. So if they go from VFib to PEA to asystole to VFib or whatever, that's a changing rhythm. And that is presumed to be a better marker of myocardial and metabolic badness, more so than downtime. And also I'll add that this is the first prognostic score that I know of which doesn't include downtime. Downtime is, as you know, so often inaccurate and it's very subjective. And so looking at changing rhythms is much more subjective. So you don't actually include downtime in this score. Anyway, this has gained a lot of support, but just a reminder, it is retrospective. And the AHA most recently acknowledged the Miracle 2 and other prognostic scores, but because they're not yet prospectively validated, the most recent AHA guidelines chose to still endorse the idea that if somebody has a post-arrest STEMI that is still class 1, regardless of mental status, that they go to the cath lab. But I wanted to bring this up just because what I'm hearing around the country is a lot more pushback and use of these prognostic scores to decide, even in the post-arrest STEMI, whether patients qualify for cath or not, which is a big departure from what we've been doing in the past. There are ongoing studies looking at whether this Miracle 2 score is going to pan out, but I wanted to just bring this to your attention because I think we're going to be hearing a lot more about scores like this and questions about whether even post-arrest STEMI should go for immediate cath or should instead go for a delayed cath. So stay tuned.
Well, one of the things I like about that is that in the other things you first showed, it said if you're, I would have been disqualified from a cath because it says greater than 85 years old. Okay, and then the European model didn't include the age thing, so you could be 90, I guess. Again, that's what I kind of like. I'm sorry about this. I got to take it, but Peter, go ahead and take the call. I got to take this call, so if you don't mind, take it from there. But then let's have Bill Palmer react to it as well. Okay.
Okay, yeah, thank you. I'm driving, so my camera's off, but I'm a great presentations. Always amazing to hear you present. My question for you relates to the fact that many of these interventionalists don't want to take these patients for fear of a bad outcome. And I wonder, this is retrospective, as you mentioned, is this being propagated by the interventionalist community? And how would you factor in this, that they don't want to take these patients anyway, so here, conveniently, we have a score. What are your thoughts about that fact there?
Yeah, my personal feeling is that probably is a factor. And I think most people that do interventional procedures, including the surgeons, in the real world, they have to worry about outcomes because CMS and other organizations look at that. I had thought that a waiver for post-arrest patients had been implemented. I'm not sure if that actually happened or not. And also, since that got put into the guidelines, I thought that had become kind of a non-issue anymore. But I don't know that for sure, and I'd kind of defer to Dr. Bommer on that.
Yeah, Bill, go ahead, because in our systems we're still seeing that. And just real quick, we saw the same thing with stroke, where for many years they wouldn't take the patient up to the lab, and then they extended it out to 24 hours. But I don't think the neurointerventionists have the same issue of morbidity and mortality that's so public as do the interventional cardiologists. But Bill, take it away.
Yeah, so we clearly publish all of our interventional and including acute myocardial infarction events. We had about 30,000 of those per year in California. Patients coming in with a STEMI and going directly to the cath lab and getting PCI. For those individuals who are in bad shape when they come in, We do have a mortality. The mortality with an acute myocardial infarction with PCI going to the cath lab is still 4 or 5%. If you look at that mortality, it is not cardiovascular mortality as much as it is neurologic. The cause of death is neurologic in those situations. And what happens is we can almost always get a patient if we have a blood pressure in the ER, and even if they're comatose, we can get them to the cath lab. We can open up their artery. We can keep usually their blood pressure adequate. We can get them up to the intensive care unit. But on day 2 or day 4, depending on the family's wishes, we have to discontinue life support because they have no neurologic function or have not had recovery. And the family says that the patient would not have wanted to consist or persist as a vegetable at that point in time. And the cause of death is uniformly neurologic at the time. So the difficulty here is that we can quite adequately, if we have a blood pressure when a patient comes in with a STEMI, get them to the cath lab, and we can open up their coronary arteries, and we can literally get their heart back and support them in the hospital. The problem is neurologic recovery is low, and that's where this point score is important, because it tries to pick out individuals who have less likely chance of surviving with adequate neurologic function to make life meaningful at that point in time. So I think it's a reasonable indication. There are individuals or interventionalists who believe that it's too hard to decide at this time. Let's just open the artery and then find out in 3 days what happens. And in that particular situation, there is, as I said, overall in California per year about a 4 or 5% mortality. And as I said, it's almost all entirely neurologic mortality at that point in time.
So Amal, do you happen to have the differentiation between the 0 to 3 group and the 4 and over group with respect to mortality?
I'm sorry, with respect to?
You said the Miracle 0 to 3 had a better outcome than the 4 or greater. Do you know what that difference was?
I don't know the specifics off the top of my head. Essentially, when the score was 4 or more, the patients that went for immediate cath had no change in outcome versus patients that did not go for immediate cath. But if the score were 0 to 3, the patients that went for immediate cath clearly did better than the patients that did not go for immediate cath. Does that make sense?
Yeah. So in other words, it wasn't increased harm. It's just that there was no difference between within that second subgroup.
Correct.
No improvement.
Yeah.
Right. So no improvement, which means that there were survivors, or there were patients who did well. I guess my question is, how do we really determine the right way forward here? Do you feel strongly that there needs to be a prospective? I mean, my sense after hearing your conversation here is that it would be prudent that we would need to do a prospective study on a score like this that's going to impact many of our patients.
Yeah, I mean, it's what they've done is retrospective, observational, and I think ideally, if you really want to know the answer, there needs to be a prospective study, even a randomized. I don't know how long it'll be before that gets done or published. But
Agreed.
Anytime you really want to know the answers, you need to get it done prospectively and randomized.
Yeah, I 100% agree on that. Paul, back to you. I see you're back.
Okay, yeah, thanks a lot. I'm sorry, that was kind of an important call I had to take on about a family doctor matter, and I had to answer the doctor wanted to talk to me. All right, so anyways, I didn't catch what Bill had to say. What he ended up saying? Can you tell me, or Amal? What did you take away from what Bill commented on, Amal?
Bill, you can do another one of your 30 seconds.
All right, in 30 seconds. Yes, we continue to have, we get about 30,000 of these a year in California. That is, patients come in with a STEMI. Our typical recommendation is to send everyone to the cath lab. That is the typical recommendation, class 1, as Amal explained, for it. The difficulty that we have, obviously, is some of those patients are comatose or unresponsive. We still send them to the cath lab. When they come out of the cath lab, we have almost 80% survival of those, even if they're comatose when they come out of the cath lab. They come up to the intensive care unit. We keep them there for anywhere from 2 to 3 days. The most common cause of death, though, is not cardiovascular at that time. The cause of death is the family comes in and says the patient has no neurologic function or is not responding, and we discontinue life support at that time at the request of the family for the neurologic reason. So the cause of death usually is brain death at that point in time and discontinuation of life support. That occurs in 5% of our patients who come in with acute myocardial infarction.
All right. So, Peter, do you have your hand up?
Yeah.
Or you hand up? Okay,
I just wanted to comment on Bill's comment because it struck me the last time that he mentioned it too, which is that we have a big issue here in South Florida with neuroprognostication. See a lot of people and families who are being told, let's pull the plug. Like, forget about 2 days. They're doing it within, sometimes in the ER. And which is why we started the Florida Resuscitation Centers of Excellence. So I wonder how much the neuroprognostication that's not being done correctly in many centers, and how much that impacts those outcomes that Bill was mentioning. So just a comment.
Ken?
Yeah, and Peter's right. We have to be cautious about the neuroprognostication. What Bill is saying is that we can save them from their cardiac standpoint, but they die from the brain damage. Then we have to look at the brain damage piece and what we can do to continue to resuscitate that. And I don't know the answer to this, but obviously, I think a lot of we're already studying plasma for TBI. And one of our theories is that the plasma will ameliorate secondary brain trauma because it stabilizes the glycothelial and prevents secondary brain swelling. Well, anoxic brain damage does the same thing, right? It breaks down the endothelial lining and allows the brain to swell, which is going to cause worsening of the brain damage. I wonder if somebody wants to study plasma to prevent anoxic brain damage from some of these cardiac deaths, see if that might be neuroprotective.
Yeah. Well, sounds like a good plan too. And then, and you know how I feel about, the parenteral estrogen too is another thought. So there's so many things here that could be at play. So, all right. Well, we got to move on to other things, but Amal, I know you stayed on a little longer than you had planned to, but I hope it was worth it. And we all enjoyed it. Obviously, it evoked a lot of discussion. Okay.
That's
And
great discussion. Thanks.
yeah. So I hope that was even helpful for you as well. Okay. So we appreciate having you here. All right. I've got to, I want to do a couple quick introductions, and I think let's do this. Dustin, why don't we have you present like next week or the week after, et cetera, but we have to get the thing out. So I'm going to still discuss it briefly before I go around the room. And, but I think we ought to give a more formal talk. Is that okay with you if we do that later on?
Oh, yes, sir. I don't know that much of a formal talk until we have the results, and the results may not be interesting. This may only interest.
Let's start the conversation, but let me do a couple introductions. Well, a couple of people. One is that Ben Weston and I had the fortunate ability to be on the call with some folks out of the American Medical Association who introduced us to some people in your. By the way, this is interesting for Peter in your Brevard County area. There is an organization there that it actually looks at women at risk, basically after in a postpartum area for eclampsia, et cetera, right? And Kim Giffords wrote it. And I don't know what your title is there. Is that like a director or executive director or something along those lines, Kim?
Yeah, director of healthcare practices.
Good, at the Preeclampsia Foundation you have. And they have I'll try to sort of quickly say it, then you can give color commentary or correct me, Kim. But what Ben and I were kind of intrigued by is that one of the things we do a lot of time when women have had babies is we, would generally give them a car seat or whatever. A lot of the hospitals will do that. One of the things that Kim and her group is saying, let's get a wristband and say, I'm at risk. Okay. In other words, they know that, we know that they will be at risk for the next, whatever it's may be, 6 weeks or whatever, or more in some cases, for eclampsia or preeclampsia or whatever it may be. And so they want to sort of get that going, but they want to also make sure it's standardized across the country. So the word got out that we have been doing work in this area, and David Miramontes is going to come back to you because they were looking for, the AMA is working for a couple of people to serve as advisors to the group and how we get this studied across the country, maybe start with a couple of pilot areas. So we're suggesting Milwaukee and we're suggesting San Antonio, because you guys have been sort of leaders in this realm for us. And so I just wanted to sort of give you one of the reasons why, and I want Kim to sort of get to know our group and maybe come down to the meeting in June, et cetera, and join us there and get to meet some of you. I think it's a very clever idea. And so I don't know, and then I want to see what people's reaction would be. But Kim, is there anything else you would add to what I just said then?
So, I mean, we've been distributing wristbands since 2020, and there are all kinds of wristbands out there. I'm able to show you a picture if you like, just to show you the different messages and stuff, but some of them say something.
You should be able to share if you could show us a picture real quick.
Yeah. Let me see. There we go. So, you can see, there's a light blue. I think in Florida alone, we have more than 5 different colors of wristbands.
Okay.
And they have different messages. Some of them say eclampsia, some of them say I gave birth. This one's special delivery, but what does that mean? And it's not very inclusive of the women that have had loss, because obviously eclampsia could still happen even after they have had a pregnancy loss. So it's not as inclusive as what we would like. So we have gotten together with the American Heart Association, Department of Health and Human Services, American Medical Association, and Premier, which has access to about 200 hospitals across the country, and have developed this wristband that you see right here. The difference between this and AWHONN, because I'm sure some of you are familiar with AWHONN's still at risk band, or actually their message is post-birth alert, is that hypertensive disorders often are asymptomatic, right? The woman doesn't feel well. She doesn't know that unless she's monitoring her blood pressure at home, she doesn't know that she is actually having an event with hypertensive disorders. So it's important to kind of get the message out. The other thing that we also did is that we added a heart to it, because less than 20% of women who've had preeclampsia are actually told that they're at future risk for cardiovascular disease. And that's a problem. The other thing that we recognize is that there's a care gap in the center of the country, in the heartland, in those flyover states. So we really want to address those rural areas as well. Our task force is formed. Like I said, those are our core groups. We've got several PQCs that are available, but I think it would be really valuable to have this group involved, because I understand that, like Dr. Pepe, you were saying, you guys have developed this sort of formula for community education and information in a way that is memorable to the staff and, will help them absorb that. And that's really important, because we need EMS providers, we need ED personnel, hospitals, quick care centers, everybody to know what this band means, so they know exactly what they need to do.
All right. So anyways, I just wanted to at least give a little bit of a heads up about this, and also for you've talked to Ben Weston, obviously, who was on the call with us the other day, and then I want you to introduce to Dr. Miramontes, who you saw talking earlier today, because they've been really at the forefront of getting education done in this area, and then we can help you. And they're thinking about piloting this in different cities, and I had suggested San Antonio, and Ben wanted to do it in Milwaukee, and so just wanted to make sure you're aware of what we were up to here, and as a spinoff, and just said, I hope that's helpful to Kim. And Kim, tell Dr. Peter Antevy is the medical director for Brevard County. Whereabouts are you located?
I am in Brevard County. Yep, that's where the Preeclampsia Foundation is headquartered, is here in Brevard. And he may already know, but actually 2 years ago in 2024, we had 2 women back-to-back die in Brevard County because they were not given treatment at the labor and delivery unit. They were sent to the stroke unit, which has permissively higher blood pressure allowances, and they ended up as sentinel events. The other thing that we know that there's a gap in care too for some of the paramedics when we went to have our blood pressure machines calibrated to make sure the ones were accurate that we were distributing. I asked one of the paramedics, hey, what would you do if you had a woman who had a blood pressure of 160 over 98? And he says, I'd ask her if she wanted to go to the hospital. And I said, wrong answer. So there's definitely some opportunity. And it's not just this area, it's all over.
I was able to tease out that it wasn't necessarily from Brevard County Fire Rescue, but another organization up there in there, Peter, just so you're aware. But we could follow up on that later on. Okay.
Correct. It was not Brevard County.
Yeah. I just wanted to make sure you're feeling better, okay, about that, Peter. But yeah, but the point is, it's right in your own backyard, our own backyard, where there's issues. All right, let me just quickly then move over to Dustin because we only have a couple of minutes. I'm sorry if I didn't get to go around the room. Unless someone has something important to tell me, let me know. There's a possibility that both Jim Augustine and I may be out next week, so we may have to roll this over to to the 16th and not on the 8th, but we'll see. I'll let you know this week. Just wanted to warn you about that. But in the interim, we do want to get Mark, I'm sorry, Mark Conrado, go ahead if you want to make a comment, but I got to get Dustin on here in a second. Okay, go ahead.
Yes, thank you. I have a request for the Eagles. I have a former medic who's now a PhD candidate in public policy who's studying whose doctoral thesis is going to be in public policy is related to EMS and regional differences. I would like to he has a study he's completing, and he wants to
put together an email or of some sort. I got
just tell me the email, and I'd like to send it out to everybody.
Send it to Jim Augustine, and Jim will sort through it, make sure it's appropriate, and he'll get it out to all the people. Okay. So
sorry for being verbose. I'll send it to Jim.
Jim, is that okay with you? I assume, right? Jim Augustine?
Yes, it is. Yep.
Okay, good. All right, thanks.
Thanks.
All right, so Dustin, you're going to be sending out a questionnaire to the Eagles here, and we like to make sure it's succinct and good and applicable. So let's quickly tell them what you had in mind, and maybe I'll start off by saying I've had experience with what you're saying is that can we bypass the emergency department? I mean, that's another way to protect the emergency department by bypassing it. So when we had a cardiac arrest in Seattle back in the day, when I was doing this in the 70s, we had a direct admit to the CCUs. So when we had a resuscitated cardiac arrest patient, we just bypassed the emergency department, went right into the CCU. We called ahead. They were all set. I think other places have even done that with OBGYN cases. I remember we had trauma cases. If they had a case coming in, for trauma cases when I was in Houston, we would go, there were certain patients we put right to the OR, et cetera. So you're looking at that for multiple other areas as well, possibly, correct? And is it feasible? Is it that, right? And you want to see, is anybody out there doing this now? Is that, have I sort of articulated that okay?
Yes, sir. So it would be a fairly short survey that you had suggested that we probably want to try and refine the wording. But this is probably something that other folks do a lot of. We are getting increasing pushback between EMS agencies and hospitals about specialty patients. The two biggest ones that come to mind are cath lab patients, so known STEMI in the field, or L&D patients, so probably greater than 20, 22, 24, whatever your line is in your city. Most of those could hypothetically bypass the ED. That's not really the question. The question is, should your crew take them through the hospital to that area, or should the ED have a process for taking that patient from you, putting your crew back in service, and taking them to the hospital? So I get both sides of it. This may be something answered everywhere else except Cincinnati, but we were going to put out a very brief, 4-question survey, seeing what your practices are, if that makes sense. Everybody, doesn't seem like a waste of time.
First of all, so what we want to ask is, do you have protocols for direct admits to certain other units in the hospital, right? that you are currently practicing or people are
Mhm.
suggesting you should do? And then what are the pros and cons that you've sort of faced there? Is that about right?
Essentially, I mean, I have the survey that I have written so far. I don't know if that is helpful to put up or not, but it's very simple. It's essentially, do you allow this for OB patients? Do you allow it for cath patients? Other, if you do so, do you require an escort? And if so, what kind of escort? And then do you require, the only other one is, do you require that your squads take in full resuscitation gear? So you normally wouldn't bring your drug bag into the ED, but would you bring it in since now you might be stuck in an elevator or something like that? So fairly straightforward.
Okay, good. And then someone I want to introduce you guys. Thank you very much. Anybody have any questions or comments before I pivot here? Okay, if not, Roger Yang, I just wanted to put you on for a second, if you don't mind. Just want to introduce you. Roger has been what forever. You've been the medical director in Pasadena. I've had the pleasure of working with him whenever I've gone out with some groups like you two or whatever. We hit the Rose Bowl, and so his crew takes care of everything there. So Roger, I want you to come on. I just wanted to say hello, and if you don't mind, if you want, can you pop in there? I don't know if you can hear me or not, but. Anyway, so Roger hopefully is still on with us and can pop on. If not, he is coming to the Eagles this year, and we talked to him yesterday. So we're looking forward to working with him and learning a little bit about. I may have him come on and talk about what he's done there. Scott Gilmore, we haven't talked to you for a while. How's things going in St. Louis? Okay.
They're going well. Been busy being the chair of the registry and keeping up with everything else.
Yeah. So you could give us a report on that. Would you mind next week, possibly, or the week after, whenever we get together, about what you're learning about the registry and what are the issues and what we should know about, or whatever. If you think it's appropriate, I'd love it. Okay. So.
All right.
Yeah. Hey, Scott, just the other thing between you and me is that what do you think if I talk about this whole issue of sex, drugs, and R&R, resuscitation and reanimation? Would that would that be okay topic for you in October?
Yes, it will be.
I'll show you a couple of things we've done. One with the plasma issues, the Castalsa verde thing. We'll talk a little about using parental estrogen and why that might be a really good thing to do. So, all right, good. I wanted to make sure I got back to you because you probably want the topic. Okay, I'll send it.
Paul.
All right. Hey, Roger, are you on now?
Hey, Paul.
Yes.
Yeah, I am. I just was driving, so it was hard to figure out how to.
Oh, that's why we can't see your face. You look like a car. I wanted to see what you look like.
You can see what my car looks like anyways. I'm in it.
All right, good. Well, anyways, if you would, Roger, maybe the next time we get together, maybe either next week or the week after, just give a real brief introduction to your system and any nuances. Just, we'll be getting an email from Jim Augustine as well, our librarian, so to speak, and asking you about how many people do you serve out there, what number of paramedics you supervise. We just do kind of a census, and we'll have you join in with us. And looking forward to.
Yeah, I'll be prepared next time. So this was wonderful. It was totally accidental that we were talking to Chief Joanna and you were on the line.
Roger wanted to come to the meeting because he had heard all this good stuff about it from everybody.
Well, and, you've been bugging me for years to come. So
he calls his phone number, and a person answers the phone immediately within 3 seconds. Right? It's Chief Q, and so she just happened to be on a Zoom with me, so we both talked to him. So we said, yeah, come on down and join us. So which will be really good. All right. Well, listen, do that for us. We've got to get off the call here pretty soon. Anybody else have anything major to report from wherever they are? Eric, anything new in your land? Eric Bank, Gladys Sada, anything? Eric, anything from your end?
No, just what I was going to comment on, and we can talk about it because I know everyone wants to get off, is what Dr. Shepke was talking about is if we're treating a TBI, are we going to start treating an MBI, right? So we're treating medicine patients. So we're going to start treating medical neurological patients. So just a thought out there.
Okay. Yeah. Well, that's it. So we'll just have to come up with a good name for it. Right. So, all right. And then, hey, Keegan, I don't know, Johanna was on and we didn't have you communicate with her. We're going to resend you an invitation to get your hotel room nailed down because we want to make sure you get the right, price and you get that. Okay. So did she send it to you yet?
I'll say thank you.
Okay, good. Did she send it to you yet? She should be sent it to you if you haven't gotten it yet. Okay, just want you to know. All right.
If I haven't received it, I blame it on Argentina's spotty reception out here at the hunting lodge.
Oh, I see. Okay, got it. Okay, so we'll keep working on it then for you. Okay, we'll keep that in mind. We're trying to get you plugged in. Okay, and then let's see now. There was someone. Oh, Glenn, anything out of New York that we should know about?
No, just the king and queen came. Luckily, a one-day trip and uneventful.
Yes, they gave you gave them the royal treatment, huh? Okay, sounds good. So, by the way, I was looking for Steve Sanko, but Glenn was really great and David Person helping them out there in Los Angeles. And with this whole controversy, I may bring that up. Some of our folks are saying, how do we justify that we should have, like, David Miramontes has 19 EMS physicians, 7 fellows, and 12 other. And that's his city of 1.9 million, and that's still not enough for all the things that he's doing. And you have a requirement in New York to have a doctor, a full-time person, an FTE for every 100 paramedics, and that's still not enough in your area, right? So is that correct? Yeah. So anyway, so that'll be a topic we may discuss later on, just so you're aware of that. Ray Fowler, we all want to salute you as usual. How are you? Anything new to report from your end, personally or impersonally?
No, just rocking along here. Perpetual rewriting of protocols, et cetera, et cetera. So,
yeah. Okay, good. Yeah, my bride was asking about you, and I said, well, hopefully I'll see him today. So there you are.
Tell her hey for me and tell her I love her.
Yeah, it was like that Buckaroo Banzai thing. Wherever you go, there you are, right? So
there you are.
All right. So let's see. I think, does anybody else have anything else to report in on to us? And that's all that they want to talk about. If not, then we'll see. Tim, your folks were good. I just wanted to know anything to report out of the Newark.
No, thank you very much. Yeah, they're doing great work. I appreciate the heads up. That talk was great.
That might be a thing for you to present there too, as well. I thought that was a good topic. We all kind of liked it, and it brings up a good thing. So just I'll add that you gave me some other topic about MIH, okay, and we could talk about maybe thinking about this one, the ultrasound one, if you don't mind. Okay,
sure.
All right, we've gone well over, and it's a sunny day out here with 8 cruise ships that I'm looking at. You guys will get to see that when you get down here. And so I'm really looking forward to seeing everybody here. It's going to be fantastic. So, all right. And Dr. Marty, I want you to know something. I sent a letter to that address, and they said that nobody's here by that address. So I need to reconfirm your address and maybe personally deliver it to you to make sure that I can tell the post office you really do exist. Okay, just want you to know. It wasn't anything.
No. Maybe the change of address thing hadn't gone through yet.
Okay.
I only got that done, about a week and a half ago. So,
yeah. Okay. Let me hear. Hang on for a second. Yeah, that could be it. I just wanted to, but this is what I got back. This is great. Here we go. This is what I got back. Does that address look correct, by the way?
Yeah, that's correct. That's
okay,
it said 33328, right? The zip.
Not only does it say 33328, but it has the +4 of 6987. Right.
Wow.
I'll figure out what happened here, but it wasn't anything important. It was more of a fun FYI.
Oh, I look forward to seeing it someday.
Yeah, right. Yeah. Well, how's the new home there in Davie?
I'm still in boxes, still trying to sort things out.
I was put on when I was younger, when I moved, last time I moved, I was put on a box a day program, right? One time I went away for a 3-day trip, came back, and I did my box. They said, you owe me 3 boxes, right? So what can you say? All right, well, listen, I think we'll go ahead and end the meeting unless anybody else has anything else to pipe in about. And I thought it was a good meeting today. It was a lot of fun. So thank you all for what you do on a day-to-day basis. All right. So welcome back, my friends, to the show that never ends next Friday, and possibly next, it'll be we'll probably be on the 15th, and I'll be reporting from Chicago at that time. I'll be out with the NBA. All right. So I'll see you all later on. Thank you so much for everything. Take care. Bye-bye.
Bye-bye.